Good morning, sir.
Good morning.
Today's my case is today's my patient is 54-year-old male, resident of Kota, Rajasthan, presented with chief complaints of intermittent fever since 1.5 months, with associated yellowish discoloration of eyes and urine with itching since 20 days. He was apparently well before 1.5 months. Then he developed intermittent fever episode, which was low grade, associated with chills and relieved by medication. He also noticed yellowish discoloration of eyes since 20 days, which was insidious, painless, progressive, and associated with high colored urine and generalized itching, and without any prodromal symptom. History of weight loss 4 to 5 kg in last 1 month, which was unintentional. There is no abdominal pain, vomiting, or recurrent biliary colic. No history of hematemesis, melena, or clay colored stool, or palpable lump. Recent onset of diabetes, abdominal distension, headache or seizures, cough or respiratory discomfort, and bony pain or backache. There is no past history of similar complaints and no history of any previous surgery. He is known hypertensive since 1 year and on regular medication. Personality, he's vegetarian by diet and non-alcoholic, non-smoker, and with normal bowel and bladder habits and normal sleep pattern. Family history, no history of similar illness in family. And patient had underwent some radiological and blood investigation. After that, he was advised for endoscopy and biopsy. Shall I summarize?
Yeah, please.
54-year-old male having intermittent fever since 1.5 months and painless progressive jaundice associated with high colored urine and generalized itching since 20 days. He had significant weight loss in 1 month and also underwent some radiological and routine blood investigation along with endoscopy and biopsy. So my differential would be, sir, extrahepatic biliary obstructive jaundice, probably malignant, and the differentials are periampullary carcinoma, carcinoma head of pancreas, and hilar cholangiocarcinoma.
So this is a case of painless progressive jaundice.
Yes,
Okay.
sir.
May I know that you are predicting a malignant cause, and may I know what is the reason for predicting this order? First is your periampullary carcinoma, second is carcinoma head of pancreas, and third is hilar cholangiocarcinoma.
Sir, first of all, the patient had the painless progressive jaundice. In
Okay.
CA head of pancreas, there might be associated uh, pain which was relating to back in epigastric region. And the hilar cholangiocarcinoma had pruritus preceding the pains.
Okay.
According to the symptomatology, sir, I have chose this order.
So what all does periampullary carcinoma constitutes, and what is the percentage of patients having pain in periampullary carcinoma?
Sir,
Am I clear?
sir CA head of yes, sir. In sir carcinoma head of pancreas, 60 to 70% of the patient had pain, and around one third are the painless. For periampullary, I'm not sure.
Okay, so what all does come in periampullary carcinoma?
Sir, the periampullary carcinoma entity constitutes the ampullary carcinoma per se, along with the peripapillary duodenal mucosal involvement and duodenal carcinoma and distal cholangiocarcinoma and small pancreatic glands
So
within 1 to 2 centimeter of the ampulla.
yeah, so the structures coming around 2 centimeters from the ampulla.
Yes.
Okay, so that will consist of ampulla of Vater, CBD,
Yes.
head of pancreas, and duodenum. Okay. So you have mentioned that he had significant loss of weight around 4 to 5 kg. So can you
Yes, sir.
elaborate on that? What is significant weight loss, and how will
So,
you predict that? Yeah, what constitutes significant
yeah.
weight?
So loss of 10 kg in the last 6 months, or
Mhm.
7.5 or 5% in the last 3 months, or to more than 2 to 3 kg in 1 month.
Okay. So it's around 5% in 1 month, or more than 10% in last 6 months.
6 months. Huh?
Okay. So any other possibility apart from these three causes?
Mm. So the remote possibility is benign etiology, sir, but I kept it,
Sorry, your voice
I
is
kept
not
it
clear.
very low, sir.
Can you repeat?
Someone's audio is on, sir. That's
I request all other participants to just mute their mic. Yeah. Can you please repeat? What are the other
yes, sir.
possibilities?
Sir, the benign etiology. for the obstructive jaundice like choledocholithiasis or Mirzi's syndrome, sir. But as the patient is not having any past history of biliary colic or abdominal pains, sir, so I did not kept it in my differential.
Okay.
And the patient had also associated loss of weight and
See,
significant
loss of
loss of
weight can
weight.
be due to cholangitis. Patient is having fever and jaundice. So loss
Yes,
of
sir.
weight can be attributed to these symptoms, not necessarily malignancy. Okay.
Yes,
So I agree that the patient is not having any significant history of pain, but
yes,
the possibility of a benign disease cannot be ruled out at this point. So I would suggest that lower down you should keep a possibility of benign cause also, because short
yes, sir.
history with fever, it can be a benign cause also. Okay.
Yes, sir.
ठीक है. So, any other possibility apart from stone disease?
And the rare conditions like the primary sclerosing cholangitis, sir. But as the patient is the
Any
short
other
history
common
of
thing apart from this?
the CAGB neck, sir, carcinoma of gallbladder neck
No, no, I am
infiltrating
talking about the benign possibilities which can cause fever with jaundice.
the choledochal cyst with cystolithiasis, sir. There might be the
Okay, so this is a
possibility of
male patient and
uh,
again no history of pain.
uh,
That is less likely. Any other
yes.
cause?
Sir, I'm not sure.
Okay, so can you entertain hydrated cyst at this point with cystobiliary communication?
Patient is not having the pain. If the if this much large hydrated will cause some right hypochondriac pain, sir.
Not necessarily. These
And
hydrated are very slow growing, and they are occasionally diagnosed on some abdominal imaging, or they usually present with cholangitis. So that might be a possibility. Okay.
yes, sir.
So, okay, Dr. Darshan, now you have summarized a 54-year-old male presented with painless progressive jaundice with fever,
Yes,
and you have entertained a malignant possibility. So, just please proceed for examination.
yes. So on general physical examination, patient is conscious, cooperative, and well-oriented, with average build and moderately nourished, well-hydrated. BMI is 21, ECOG score is 1. The patient is vitally stable, afebrile at the time of examination. Teres is present and scratch marks, no paler cyanosis, clubbing, pedal edema, or lymphadenopathy. On abdomen examination, on inspection, abdomen is flat with scratch marks seen. Umbilicus is central and inverted with no fullness or visible lump and no visible scars, peristalsis, pulsation, sinuses, or engorged veins. Hernial sites, no visible cup impulse and external genital are normal. On palpation, that there is temperature of abdomen is normal, soft and non-tender with palpable gallbladder present and liver and spleen are not palpable, no other palpable lump, and hernial sites, no palpable cuff impulse present. On percussion, liver span is 12 centimeter in midclavicular line, flanks are tympanic. On auscultation, normal bowel sounds heard. On digital rectal examination, perianal skin normal, sphincter tone normal, no palpable mass, and glove finger stain with normal stool without melena. The rest of the systemic examination is normal. Shall I summarize?
Yeah. So, in your general examination, or especially in abdominal examination, whenever you are presenting a case of jaundice, it's just better to either in negative history or positive history, just to give us idea about features of chronic liver disease.
54 male having since 1 5 months and painless progressive jaundice associated with high colored urine and generalized itching since 20 days. He had significant loss of weight in 1 month and underwent radiological and routine blood investigation and endoscopy. On examination, scratch marks seen all over the body and indicated palpable gallbladder present. So, uh, from the examinations, I have ruled out the hilar cholangiocarcinoma from my differential, and the possibility came down to periampullary and C-head of pancreas.
Okay. So, why the gallbladder is distended?
So, due to distal block, sir, due to distal block in the CBD, sir, the gallbladder distension is
What is this sign or
curve
phenomenon called?
of so Kurzweil's law. In case of malignant obstructive jaundice, sir, the palpable GB is seldom due to cholelithiasis or cholecystitis.
Due to stone disease?
due to stone.
So can you just enumerate the exceptions?
Sir, if there is a double impacted stone, like in the CBD stone along with the GB neck calculi,
And any other?
then any parasitic infections like oriental hepatitis causing GB distension.
So now you are left with two possibilities of either a periampullary carcinoma or CADA pancreas. You completely ruled out any benign possibility.
Yes, sir.
Okay. So how will you proceed now?
Sir, I would like to review all the previous records, sir, of the patient.
Okay. So suppose the patient has lost all the previous records. How will you proceed from here now?
Sir, I would like to do first, sir, two sets of investigation. First, the screening investigation, and then to confirm the diagnosis of the patient for the staging of the. So, I would
Okay.
like to do some general blood investigation first, as the patient is jaundice and icteric, sir. I would like to do first, and also having some recurrent fever episodes. So, possibility of cholangitis is there.
Mm-hmm.
So, complete hemogram, sir. Then liver function test, then renal function test along with serum electrolytes, and PT, APTT with high NR, sir.
Okay. So do we have all these blood investigations?
Yes, sir.
Hmm.
These are the serial investigation from the time of diagnosis till now, sir. So the TLC counts are increased on the 9th of November. It's around 13,000. Along with deranged LFT, the total bilirubin recently is 1.7 with direct bilirubin 1. SGOTPT are 200 and 264, 262. And the level are within normal range with normal NR and electrolytes.
Okay. So what does this
Uh,
indicate?
patient had also, the patient is having uh, uh, the obstructive pattern of the jaundice from the LFT along with sir, SUT and SGPT. Subclinical cholangitis is also there.
So what do you mean by subclinical cholangitis?
So no obvious features of like fever,
Patient had fever.
but without any. Uh, but it was intermittent. Sir. It was kept. It was resolved at the time of examination.
Patient had fever, na? The patient main complaint was fever. So,
Yes, sir.
so it cannot be a
Yes.
subclinical cholangitis. है ना? With deranged
Sorry.
LFT
It's
and
cholangitis.
raised TLC and patient is having fever, so it is cholangitis. So how do you grade cholangitis?
So it is graded according to Tokyo guides, grade A, grade B, and grade C. In grade A, sir, there is clinical features like fever, tachycardia, and in grade B, sir, the imaging, so the systemic involvement, like patient is having hypotension or along with some multi-organ involvement, and in grade C, the imaging, which are
Sorry. So now I think you
cannot
have
actually
given
remember
me
the
some
grade.
criteria for diagnosis and then criteria to grade the cholangitis.
Yes, sir.
Okay. Okay. So now these are the investigations of the patient. And what will you like to do next?
Sir, I would like to do first USG whole abdomen and chest X-ray sir,
Okay.
to to this is the USG abdomen of patient. It shows the intrahepatic biliary radicals are dilated in the both lobes of liver with dilate up to the lower end and just 10 mm. Rest of findings are normal.
Can I have the slide of ultrasound? So what
I
all
don't have a
information do you
slide.
require? What all information do you require from our ultrasound? Is it sufficient or any other information is
Sir,
needed?
any sir enlarged lymph nodes is there or not? Or presence of ascites is there or not, and if there is seen any mass, so in the head or the uh,
So no, go
any.
systematic. Go
Yes.
systematic. First, you have to make a diagnosis. Okay.
Yes.
So for making a diagnosis, what all do you need? Patient
So
is having jaundice.
John,
Yes. What will you look in ultrasound with the patient of obstructive jaundice?
first of all, sir, any stones, any stone is there or not in gallbladder or in the CBD?
So first of all,
And
you confirm whether it is obstructive jaundice or not. So you'll like to look at in IHBRD, intrahepatic biliary adrenal
yes,
dilatation. Next thing you look at the level of block.
yes,
Okay. So where is the level of block? Whether it is at the hilar region or subhilar region, or it is a distal block. Okay.
yes,
Next thing you like to do, what is the cause of that block? Okay. Whether it is due to some stone disease or there is some mass lesion or there is something else. Okay. Then you
yes.
come on to other ancillary findings. What other ancillary findings would you like to see on ultrasound?
Any uh, enlarged nodes or and
Okay, lymphadenopathy 1.
lymphadenopathy, then
Okay.
presence of ascites,
Ascites. Okay.
then any liver SOL or
Okay. Anything else?
any if there is dilated uh, CBD along with PD, double duct side is there or not?
Okay. Any other information you can get from ultrasound? Can you comment upon the ego texture of the
Yes,
liver?
yes, sir. If there is any CLD, underlying CLD is there or not? Echo textures from the echo texture pattern.
Okay. So these are the things you can grossly look upon a good ultrasound can tell you. Okay. So you just
Yes,
have to proceed systematically. And now what you have to look in ultrasound. Okay. So first you have to confirm whether it is obstructive jaundice by looking at IHBRD. Then what is the level of block, then cause
all
of block, and then features, other features like what is the status of underlying liver or any other features suggestive of advanced malignancy or cholangitis. Okay.
yes, sir.
Okay. So now you have this ultrasound. The patient had fever, raised TLC, and deranged LFT. What will be your next step?
For the confirmation of the to localize the sir, level of block, sir, I would like to do this CCT whole abdomen with pancreatic protocol, sir.
Okay. So before that, would you like to admit the patient to give some IV
Yes,
antibiotic hydration
yes,
so that this LFT can be improved and before going for a CT scan?
yes, sir. First, I would like to admit the patient and give adequate fluid resuscitation along with antibiotics, sir.
Yes. So this is the important part. Na? So just
Yes,
before rushing on to the CT scan, you'd also see the clinical condition of the patient. Patient is
yes,
coming to you with fever and on investigation raised TLC and deranged LFT. So
yes,
after doing preliminary investigation, better to admit the patient or just give antibiotics and then see how he behaves. And then
yes,
maybe a repeat set of investigations after 48 hours if patient is not having any organ failure. And then you can go for a CT scan.
sir.
Okay. So you mentioned a pancreatic protocol CT scan. So what do you mean by a pancreatic protocol CT scan
Yes,
and in which conditions it is recommended?
sir. Uh, in the peripheral pancreatic malignancies, the pancreatic protocol is advised, and it includes the three-phase study. The first non-contrast study, then second at the uh, contrast injected and image acquisition at the 45 to 50 second, the dead arterial phase or pancreatic phase, and then the third at the 60 to 70 second, the portal venous phase. And the ear slice are 1 mm slice thickness.
So you do you routinely get a pancreatic
And
protocol CT scan in a periampullary carcinoma or just a triphasic CT scan is sufficient?
no, sir, if there is a presence of double duct size in
So
so
basically the
the
idea is
possibility of the CH,
so basically the idea is for getting a pancreatic protocol is whenever you are confirming a pancreatic pathology, like those lesions who are arising from pancreatic parenchyma, like neuroendocrine tumors
yes,
or something else. okay, insulinoma or any other
Did,
thing. So then a pancreatic protocol is really helpful. Otherwise, when there is a distal block and patient is having obstructive jaundice and ultrasound is suggestive of a growth at ampullary region, a triphasic CT scan is sufficient. Okay. Okay. Now you have resuscitated the patient and patient's renal function is improved. It was okay also. And you have got a CT. Do you have a CT scan?
yes, sir.
Okay.
So we have actually films. It was done outside.
Okay. So do we
In
have
this,
the cut?
sorry, sir.
Yeah, just if you can present
Yes, sir.
those images.
Yes, sir. In the
I'm
axial
not
section,
able to
we
see
can see
the image.
is it visible?
Not yet.
चेक हो रही है 9 बज के 25 मिनट हो गया
Is there a problem with my screen or everybody is not able to see?
None of us are able to see.
Oh, good morning, sir.
Good morning.
I reshare the screen, sir.
Yeah,
Is it visible?
not yet. So, meanwhile, can you just
Yes,
read out the images if you are able
yes,
to
sir.
see at your laptop?
Yes, sir. Sure.
Mhm.
The uh, axial sections of the uh, abdomen, sir, it shows the liver, the bilobar IHBRD, sir, with no any cholangular abscesses, with well distended gallbladder and dilated CBD.
Okay.
So the axial section shows bilobar IHBRD, sir, along with
Mhm.
dilated CBD and distended gallbladder. The PD is also dilated.
Mhm.
Trace it down. The double duct sign is positive, and the we can see in this section also PD and the CBD are seen separately.
Okay.
In the lower section, we can at this level the P is not visualized. Mass is also not appreciable. Something is I cannot appreciate the mass.
Yeah, so mass must be below the level of obstruction. Na? The CBD is dilated till the last cut, so it must be below that.
This to this the CBD is dilated. Then
Yeah,
the
so
CBD is not
we have to
dilated.
look
The
at the
PD is
images
also not
below this.
visualized. So at that level,
So can you comment what is the phase of this CT scan? And
from this phase, it is delayed RTL or portal venous phase.
okay,
The
so
contrast in the some contrast in artery and the portal vein is enhanced. The portal vein is uh, well enhanced in this
mhm.
section, while the arterial contrast is in the delayed phase. Probably the arterial or portal venous acquisition at that time.
Your voice is not clear. Okay, so do we have the cuts below
Hello,
this?
sir.
Do we have the more cuts so that we can see the mass lesion or pathology?
I have coronal reconstruction.
Coronal reconstruction. Okay.
In this, the double line is getting mass is not visualized.
Mm-hmm.
The thick sections, that's thickness is also better.
Can you comment how much thickness of this CT scan is there from reading these cuts?
10 mm, sir. The
10 mm.
is
So how do you
10
infer that?
mm thickness is there, sir. So the it shows the left
Sorry?
section images.
Yeah.
The section images, sir, it shows the 220 serial numbers of 270, 283, the 10 mm interval, the images are given.
So these are 5 to 8 mm. Okay. Can you see the number on the top right hand side of each image? 160,
Yes,
166,
sir.
172, 178,
Yeah, one. Yes, sir.
185. So these are 5 to 7 mm. Okay, so these are the cuts at which these are the markings at which this axial cuts have been taken. So these are not 10 mm, but yes, 5 to 7 mm. Okay, so in these 5 to 7 mm cuts, you are not able to see the mass lesion. Okay, so mass
Mass.
must
There is
be
no mass
smaller
in the
than that.
pancreas.
Okay, sorry.
Yes. No visible mass in the pancreas.
Sorry, I'm not able to get it. What are you saying?
Hello. no visible is some temporary thickening which is visible, but the
Where is
current
the
mass is not visible.
okay? So what other things you will look in the CT scan? Can you comment other things on what are these visibles in this scan and what
Uh,
else you should look on the CT scan?
May I ask a question?
so,
Yeah, sure, sir. Please.
Yeah. You have a dilated pancreatic duct.
Mhm.
You have obstructive jaundice. Could this be groove pancreatitis? Could it be chronic pancreatitis? How do you differentiate the two when you're not seeing a mass lesion?
sir, it can be, but sir, as per the clinical history, the patient had never history of recurrent pain or
That's
any
not
previous
required.
episode of
That is not required.
varicose
In
or pain.
30%, in 30% of people, there is no pain. Only in 70% of people, there is pain.
And there is no chronic
You can't
pancreatitis
rule it out.
changes
You
in
have
the
to include it as a
pancreas.
differential diagnosis based on the imaging. Based on the imaging, you have to keep it as a differential
Yes,
diagnosis. Yeah, go on, please.
Yes. So we were
yes,
discussing what other things you should look in the CT scan.
yes, sir.
Hmm. Go on systematically.
First of all, sir, yes, lock, sir. First, so where is the pathology is situated, sir? It is a lower end CBD block of the C head of pancreas. Then the any lymphadenopathy is there or not, sir? Signs of uh, distant spread like liver mets or lung mets is there or not, sir? Or ascites. The liver echo texture
Echo texture is
is a
usually commented on a ultrasound. In CT, what you see is density. Okay.
dense.
Hounsfield unit. Okay. Hypodense, hyperdense.
Yes,
So whenever we are looking for a periampullary pathology, so better to go systematically. So either you go in a reverse way, M and T, or in a forward way, describe the T, then N, then M. Okay. So what all things you should look to describe a T
yes.
stage.
The site of lesion, sir. The site
Okay.
of the lesion
Site of the lesion is
is
periampullary. So
the
what other things you should describe
periamp.
describing a periampullary lesion in the pancreas or in a periampullary region?
So it is the underlying duodenal infiltration or the
Okay.
pancreatic infiltration is there or not. Then
Okay.
the level, the measurement of CVD and the dilated PD, sir.
Okay.
Then double duct sign is visible or not.
Mm-hmm.
Then uh, uh, the vessel involvement, sir.
Yes. What all
The
vessels are important?
the portal vein or the SMA involvement or portosplenic confluence involvement is there or not.
Can you show us where is the portal vein and where is the SMA in the CT scan? One
So
slide back.
these are the SMV, sir, and this is SMA. This
Sorry.
cut, sir. This
Yeah.
is the SMV
Uh-huh.
and this is SMA, sir.
Okay.
It is not involved. Actually, the mass is not so visible. So in, the
Oh,
involvement is cannot be commented.
yeah. So involvement can only be commented at the relation to the mass lesion. So in this cut, the CBD is dilated. So any pathology
Yes,
must be below the level of dilatation. So whenever there you see a abrupt block, then only you can
yes,
comment the relation with the vessels. Main is the portal vein and the SMA. Okay. Any other thing
yes.
for completing the T stage? So usually,
I don't. I cannot recollect, sir.
to also to better to say the relation with the IVC.
Yes.
Okay. In the
Oh,
case of
in the
pancreatic pathologies.
yes,
Okay.
sir.
Okay. So next is the nodes and what all the nodes you are interested in and what are the stations you will look at in the CT scan.
So for the periampullary and this C head of the pancreas, sir,
Yes.
the station 5, 6, 7, 8,
Mm-hmm.
then station 9, 10, then 12, 13, 14, 16.
Okay. So what are these lesion stations? 14 and 16?
14 are sir, SM and along the SMA.
Okay. So is there any further subdivision of patient 14 and 16?
I don't know, sir.
Okay. So you can read that. Okay. So
Yes, sir.
what node, if on CT scan, if you see that, will you deem this patient as a metastatic or non-regional lymph node?
Uh, the the size of the node is more than 1 centimeter. Then
No, no.
heterogeneous. Yes,
I'm asking about the station. Which station, if seen on CT scan?
yes.
Yes, go on.
So if there is a presence of interaortocaval or para-aortic nodes is present, and
So do we label them as metastatic in case of CA head of pancreas?
also, but the prognosis, if they are present, the prognosis of the patient is not good.
No, no, that is a different thing.
Yes.
So, but would you label them as a metastatic non-regional lymph node?
No, sir.
Okay.
If there is any neck nodes are present, sir, no,
Yeah.
they are make the patient the metastatic supraclavicular lymph node
And there are nodes, large nodes in the mesentery, root of
and the
mesentery,
and the
that will not come in your resection area or any other distant node, like you said, in a supraclavicular area that you have to see in a CT scan of a chest and neck.
yes,
Okay. Uh, then come on the M staging, liver lesions or any other distant mets in lung or anywhere else in the body.
bony mats or
Bony mets. Okay, that is less likely. Okay, so can we have the final report?
yes, sir. The report shows the dilated CBD measuring 14.8 mm in the neck
Mhm.
region, along with dilated CBD measuring 5 proximal body regions and ill-defined heterogeneous attenuation area, mildly enhancing the post-contrast Hounsfield unit is 56, measuring 1.7 centimeter to 1.5 centimeter in the distal CBD with cutoff of CBD and upstream dilatation with CBD and PD. Double duct sign is seen and IHBRD in the both lobe of leaf.
Mhm.
And rest of the features are normal. The
Okay,
portal vein and the hepatic veins are normal.
okay. So it is a periampullary pathology. What will you do next?
Sir, I would like to do the side view endoscopy, sir, first
Okay.
to
Why
see the.
endoscopy?
They have mentioned the periampullary etiology, sir. So
Mm-hmm.
in the normal scope, is it not?
No, I agree. You want to see the
Yes, sir.
ampulla, you have to do a side wing endoscopy, but why
Yes,
do
sir.
you want to do that?
So for the confirmation of the diagnosis, sir,
How
to
will you confirm the diagnosis on an
biopsy
endoscopy?
for the upper GI and the biopsy of the lesion.
So yes, so you should tell it completely that I would like to
Yes,
get a side wing endoscopy and
with and
biopsy of the
biopsy.
lesion. Okay. Was it done in this patient?
Yes, sir.
Okay.
Uh, this is the side view endoscopy, sir. It shows the
Mm-hmm.
bulky ampulla with eaten up tip and the biopsy taken. And the biopsy turns out to be inconclusive, sir. There is no evidence of any dysplasia or neoplasia seen in this tissue.
Okay, so that's interesting. So now what will you do?
Sir, the patient, the the pathological report is inconclusive. Imaging features and the clinical history, the radiological features are strongly suggestive of periampullary carcinoma.
Mm-hmm.
So after uh, yeah, take the patient for the surgery
Okay. So any other investigation you can do
because
for better counseling of the patient?
Can you do
we
an
can do the
endoscopic ultrasound?
endoscopic ultrasound and FNA.
Yeah.
Yes, sir. Yes.
So
First we can do the endoscopic ultrasound and FNA.
yes. So just directly before jumping on to surgery and counseling the patient, if in current scenario, if you are unable to prove a diagnosis from one investigation, I think you should completely exhaust other investigations also before planning any major surgery. Okay.
Yes.
Any other investigation that can also help in characterizing the mass lesion apart from EUS and FNAB?
Cholangioscopy, sir. We can do the spyglass cholangioscopy.
Cholangioscopy.
Why not a regular
For the
ERCP?
distal CP.
Why not an ERCP? It could be a
Sir,
stricture in the distal bile duct
in
or an
the,
impacted stone that you will be able to see only if you give a pre-cut and see. You have to give a pre-cut and then see what you're able to see and take a biopsy. And also, you have to do a cholangiography and stenting. Because once you do cholangiography, you are contaminating the biliary tract. So you have to do a stenting simultaneously.
yes, sir.
But pre-cut is required to take biopsy from the bile duct. Very likely, this is a lower end cholangioCA. That's why the ulcerated area has not shown any evidence of biopsy.
Yes, sir.
Yeah, I agree with sir. So, like ERCP is one modality. So, before that, also, if it is available, you can also do a CE-MRI with MRCP. Okay, so that will give you also a lot of
Oh,
information to characterize the mass and also about any presence of stone or features of what is the cause of obstruction. And importantly, it is a non-invasive investigation. So, if you say in your exam, then you will not be incorrect. And this investigation is always scores over a CT scan. So if you're available, it should be done. And in exam, you should always
yes,
tell
sir.
that CMRI with MRCP can also be done. Okay.
Okay, sir. Yes, sir.
Suppose after doing EUS also, there is a small lesion and the FNAC is also inconclusive. Now what will you do? Am I audible?
Yes, sir. Yes.
Okay. Okay, you
Uh,
got my
if
question?
the FNAC is, yes, sir.
Again, inconclusive
If
after
the
endoscopic ultrasound, but EUS shows
EUS,
mass lesion of around 1 by 2 centimeter as shown in CT. Now, what will you do next?
if the US features are, if the US features are in the favor of malignant lesions, sir,
Mm-hmm.
then we can explain the patient, sir. Or there is a possibility of the high possibility of malignant etiology, but
Mm-hmm.
also there might be a benign cause which causing this.
Mm-hmm.
So before explaining for the surgery, you have
Mm-hmm.
to explain all the pros and cons of before going for the operation.
Yeah, exactly. So, like before, if you have done enough investigations, then it will be better for counseling for the patient that see you have already exhausted all the investigations but unable to prove, but
Yes,
the lesion is causing jaundice, you are having fever, and all the investigations are suggestive of malignancy. So, you should better plan for a surgery. What surgery would you plan in this
yes, sir.
case?
Uh, this is the temporary pylorus preserving pancreaticoduodenectomy in this patient.
Pylorus preserving pancreatitis. What are the types of pancreatitis you know, and why do you choose
The
pylorus preserving? And would you like to do anything else before doing a pylorus preserving pancreatitis?
the pay the tumor the tumor marker level, sir, the
Yeah.
CA99 level.
Okay. So CNA
At as this was normal around 6.
normal.
So yes, sir. The imaging features and the CA99 level so they are not suggestive of any distant mets, sir. So I
Uh-huh.
would like to do for the upfront surgery rather than for staging lab, then proceed for surgery.
You will not do a staging laparoscopy. Hmm?
So the imaging features and the from that, sir, the possibility of the distant meds, distance spread is low, sir.
Okay. So in our setup, it is very easy to do a staging laparoscopy. है ना? Patient does not have to pay
Oh,
anything
yes, sir.
extra. You can just put in a scope and see. And so I agree
Yes,
when
sir.
in scenarios when the patient has to pay extra for staging laparoscopy, then staging laparoscopy should not be done, especially in these cases where there are low chances. But in our scenario, in Indian scenario, it is very easy to do a staging laparoscopy. Do you
Yes,
agree?
yes, sir.
है ना? So in all Western countries or other countries, when patient has to pay extra for a separate procedure, then it is contemplated or debated that whether you do a staging laparoscopy or not. But in our cases, patient does not have to pay anything extra for staging lab. And with the same armamentarium, we can do a staging laparoscopy. So it is always better to do a staging laparoscopy. Okay.
Yes, sir.
Hmm.
So after
Okay.
ruling out,
Yeah, yeah.
after yes,
So
after ruling,
last question, what are the types of pancreatenectomy you know?
sir, the classical Whipple's pancreatic
Mm-hmm.
duodenectomy, the Longmire Traverso, the pylorus preserving pancreatic duodenectomy, and those
Mm-hmm.
are extended resection according to ISGPS. The type 1 is standard PD, type
Mm-hmm.
2 is PD plus vascular resection. In type 3, the multivisceral resection is there, and type 4,
That is
PD
extended.
plus.
Okay.
Yes,
So what is one is classical, one is pylorus preserving.
yes, sir.
Anything, any other modification?
And
What is antrum resecting
Yeah.
pyloro
subtotal, yes,
pancreatitis?
sir.
Yeah. Do you know about it?
No, sir. I don't know.
So one is antrum resecting or pylorus resecting, PRPD. Okay,
Yes,
some
sir.
people call it subtotal or some people call it PRPD. So it is another modification of pancreatenectomy, as sir already told. Okay,
Okay, sir.
Dr. Darshan, uh, good case presentation. Sir, any comments before we close on this session?
Ask him some more questions about pancreatic duodenectomy. I think we still have some 5 minutes.
Okay, so you were saying about the extended pancreatenectomy. So can you
Yes,
just briefly touch upon what is that?
they're classified in the four types, sir.
Mm-hmm.
In type 1, the standard PD here.
Mm-hmm.
In type 2, pancreatic duodenectomy plus vascular resection,
Mm-hmm.
concomitant vascular resection. In type 3, the multivisceral resection like major HPD cell,
Mm-hmm.
hepatopancreatic duodenectomy. And in type 4, the arterial resection is also included along with PD.
ठीक है. So can you tell how will you do a pancreatenectomy? Which approach will you follow? And can you briefly describe the steps?
So first of all, sir,
Hmm.
uh, we'll start with the bilateral right subcostal, extended right subcostal incision, sir, and
So you are planning
first
for a open pancreatenectomy.
open. Yes, sir. I
Okay.
will. Yes,
Okay. So open, what incision will you give?
sir. Right subcostal incision with extension overlap, sir.
Right subcostal incision with extension
With
over the.
the
What is the other name for this incision?
hockey stick incision
Hockey stick
or
incision.
more
Or
or
rooftop incision.
rooftop. It's not.
Okay.
Yes.
Okay. So next.
Then first of all, see there's any evidence of distant mats is there or not, sir.
Mm-hmm.
First of all, I will check the subdiaphragmatic surface, peritoneal surface, then pelvic deposit is there or not, omental deposit is there or not, then the liver and the
Mm-hmm.
root of the mesentery, is there any puckering is there or not, and the transverse
Mm-hmm.
mesocolon.
Okay.
Yes. Then uh, I would like to cockerize. First of all, I would do the extended duodenal cockerization, sir.
Okay. What
Then
is
see
extended dural
What is
cockerization?
extended cauterization and what is standard cauterization?
uh, up to uh, uh, I, up to the IVC, sir. And if we are just beyond the IVC and we can see the left renal veins, it is extended.
If you go to the left border of the aorta, then it's
Okay.
extended. If you stay to the left border of the IVC, it is
Yes.
standard coccus.
Then I will see that if there is involvement of any vessel is there or not, sir. SMA involvement is there or not, sir. The right posterior approach, sir. SMA first.
What is artery first approach? What are the various artery first approaches?
So there are six artery first approaches, sir. The right posterior approach, then superior approach, left posterior approach, then infracolic approach, then mesenteric approach,
Okay.
and the anterior
So
approach, sir.
which one would you prefer to do in this case?
So the right
Would you
posterior
do an
approach, sir.
artery first approach or you could straight away proceed to Whipple's?
In this, sir, we can straight away uh, proceed for the people, sir, as there was no special involvement on the scan, sir.
Okay.
Then after cauterizing the duodenum, sir, I would like uh, open the gastrocolic. I will open the lesser section, and after
The six major steps of
yes,
pancreatic.
yes, the
First,
duodenal cauterizing.
cauterization,
Then, sir, gastrocolic.
I think best described in mastery. Visual.
Yeah. And in Fisher, he advocates for neoadjuvant chemotherapy for pancreatic head mass.
Yes, sir.
Yeah, I think that is slowly starting to change now, that we are starting to see more and more application of neoadjuvant chemotherapy to increase the survival,
Definitely, sir.
especially if it's a mass head of the pancreas that's indicated. What is the classification of this thing based on the resection?
Can you repeat, sir? Can you repeat again, sir? What?
Based on resection of the pancreas,
Yes,
what
sir.
are the various structures that you remove? In this patient, what all do you want to remove?
Okay. Sir, the transaction line at the bowels, sir, it be just beyond the pylorus, sir, 1 to 2 mm. At the D1 cuff is maintained. Then the pancreatic neck transaction just above the portal vein, and
Okay.
the distal transaction is just after at the DJ junction, just beyond the
Okay.
DJ.
You know that
And the distal,
delayed gastric emptying is one of the side effects of pylorus preserving pancreatic duodenectomy. What strategies you will use on the table to minimize that effect?
the pylorus stretching can be done, sir.
No, you will not pull on the pylorus because the nerves of lateral jet will get stretched and neuropyrexia will occur. That is one thing. You should make sure that there is no congestion of the cuff of the duodenum when you have
The vascularity of the duodenal cuff, sir. So
Yeah. So those
duodenal
are
cuff
two
vascular.
things. What is extended lymphadenectomy and what is standard lymphadenectomy?
Sir, according to the ISGPS, they have mentioned the lymphadenopathy station. Include, sir, if we are just staying just the left of the celiac trunk, sir, it is standard lymphadenectomy, and we are going
Left or right?
right, sir. Sorry, right. If we are staying the right of the celiac trunk,
Okay.
it's a standard lymphadenectomy.
So there are specific stations which have to be removed extra in the extended lymphadenectomy. You have to go and read about it. Okay.
I think time is over. We can stop now.
Yeah, I think so. We can close this session. Okay. Thank you, Dr. Darshan.
Thank you, sir.
And thank you everyone for joining.